Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in another demonstration video of our soon-to-be-launched WAXscope, which now has an official launch date of Friday the 12th of April 2024. And initially I was a bit pessimistic about uploading this video because I know some viewers may not like the optics, particularly because this patient's ear is really, really narrow, and I might get a few negative comments, but oh well. This is one of the reasons why we developed the WAXscope. So as you can see, this patient's ear canal is extremely narrow. The ulnar suction probe, which has an outer diameter of around 2 or 2.1 millimeters, can only just fit into the ear, and that's after semi-dilating and stretching the ear open using the WAXscope. So in the absence of the WAXscope, when I was using the endoscope, what we'd have to do is just insert the endoscope just to the left of the suction probe, where you can see the suction probe just a moment ago, and you can see the flesh on the left. That's the first bend of the patient's ear canal. So I'd insert the endoscope to the left and push that cartilage to the left wide open. And if I wasn't able to do that, then I just simply wouldn't get the instrument into the ear. And that can be a difficult skill to do when you're using both hands, one hand to stretch the ear, the other hand to manipulate the instrument into the ear. So with the WAXscope, it's easier because you've got the speculum. And I'm using the speculum to instead straighten and stretch the ear canal in order to stabilize my hand. Another potential issue in this particular case with an endoscope is because of the hairs, and because I'm having to insert the endoscope into the ear to stretch open the ear just past the first bend. And it's happened last time I was reading through my clinical notes with this patient. The lens of the endoscope would get easily blurred by all the hairs because the endoscope will be in between those hairs. But with the WAXscope, although you do see some hairs, I mean, the patient's got hairs in the ears, I can't do much about that. The lens is further out, and so therefore it's not obscuring the view as much. And you can see now we're really dilating the ear. I've gone a bit further into the ear. Another thing with the WAXscope, and this is just more for viewers who kind of just, when you're kind of wondering why the view's so different to an endoscope. So with an endoscope, the lens is inside the ear, hence the term endoscope. And the endoscope also has what we call a negative lens. And what the negative lens does, it kind of widens the field of view. So it makes it panoramic. With all other visualization methods, so anything other than an endoscope, you're not going to get that same optics because the lens is outside of the ear. You can call this an exoscope if you like. And therefore, you don't have a negative lens, because if you have a negative lens on a magnifying lens that's outside of the ear, well, it's going to widen the field of view, but not of inside the ear. You're going to see more of the patient's cheek maybe, or jawbone, or the back of the ear, the mastoid bone. So that's what gives the WAXscope and an operating anti-microscope and head loops kind of a narrow field of view, which is, yes, it's one of the disadvantages in comparison to the endoscope. So each visualization method has its own pros and cons. So the thing that kind of really inspired me to make the WAXscope is, although the endoscope's got such an amazing field of view, it's kind of a pointless field of view if people kind of don't enjoy using the endoscope and they find it difficult to handle and operate. So therefore you have to kind of have a compromise, and the WAXscope for me, and I'm obviously going to be very biased, it's probably the next best alternative. So it's not perfect, it's not a substitute for the endoscope, but it's a really good substitute or an alternative if someone can't use an endoscope. So again, just stretching the ear open. And so when the lens is not inside the ear, there is also a constant need to refocus. Again, you can't avoid that. It's the same with an ENT microscope. So whenever you remove a layer of wax, and then you're going deeper into the ear, whether it's the head loops. With the head loops, you just move your head forwards and then you kind of stabilize your head to get the focus. With an ENT microscope, you manipulate the optical unit. So you have a handle there and you kind of move that forwards and backwards. But with the WAXscope, there's a little slider on screen and you just slide it to just the focus. There's also an autofocus option as well. So the right ear is all cleaned, nice healthy eardrum, and this left ear is even more narrower. And it was actually difficult for me to stretch the ear open using this size specular, so I'm giving it a good go there. And I did actually give credit to myself, I did actually dilate it, but when I go a bit further, I want to put the speculum deeper into the ear, so you will see me revert to the smaller specular. So this specular is our medium, our standard size specular, if you like. It's 4.25 millimeters in diameter. The smaller one is 3.5. So I've just put quite a lot of medical grade olive oil in this patient's ear because the wax, it's got a completely different consistency to their right ear. It's a lot more kind of stickier and almost like a mashed potato consistency. I just don't know which other analogy to give, but when you put the oil in, it helps to bind this together, so it makes it easier to vacuum. So I'm just trying to loosen this from the floor of the ear canal. As you can see, there's some skin adhesions here, so we're just trying to manipulate, and I'm going to the back part, and you can see past that first bend, which is to the right, the ear canal balloons open. It's wider in the midsection, which can make earwax removal a bit more tricky because you're having to kind of almost manipulate this and bring this through a narrowing. And by softening the wax, that does help. And here, I'm just going to get a suction grip and kind of drag it down through. So I'm just going to the top now to see if I can loosen it from the top. So again, I'm just bringing the suction probe down and then to the front part of the ear canal. And I think in a minute I'm going to revert to the smaller specular. So if you are a clinician or performing earwax removal and you want to learn more about the WAXscope, please do email info@clearwax.co.uk, or if you're a suitably qualified clinician but who have yet to expand your scope of clinical practice to perform earwax removal, again, feel free to contact us on info@clearwax.co.uk. So again, I'm just going to the bottom. So you can see here that the surface of the wax plug's really in focus, and as you go deeper, it slightly gets out of focus, and that's another compromise, which if you're not using an endoscope, whichever the visualization method you use, it is going to be another compromise. So we're getting deeper into the ear, and I think I'm going to go to the top. There we are. And just dragging it down, so the wax is quite matted as well, and there's a few skin adhesions. And I'm just getting a suction grip, bringing down, suction grip, bringing down to loosen it. I think I've just dosed the ear with a bit more oil, so we're really stretching the canal open there. So once you get the instrument in, it can move some of those hairs out of the way, so that's handy. And again, I'm just going to go to the back there and to the bottom. I'm just going to clear some of this at the entrance just to get a better view of the front part of the ear canal, so it gives me more awareness of where the instrument is in relation to the patient's ear anatomy. We don't want to be bumping into the canal wall, especially the bony part, because that would be uncomfortable. And just, again, just trying to prevent the suction flow from getting blocked because of the consistency of the wax. It's almost got a chewing gum consistency here. So yeah, I'm going to stretch the ear open. And stretching the ear open with the speculum, it's something that obviously as an audiologist is what we get trained to do using an otoscope, but I'm so out of practice using an otoscope because I don't use one. I use an endoscope where you don't have a speculum. So it took me a while just to kind of refamiliarize myself. It sounds odd, but when you're used to doing something in a certain way for so many years, you have to rebuild your muscle memory. So, and whenever you use a speculum, you're always worried that is it going to be uncomfortable for the patient, and it's not. It's the outer third is a cartilaginous portion. The speculum is designed not to be over inserted. So if you have a outside view of it, it's got a flared angle. So it's only so far you can put it into the ear. And the idea of that is that you can't over insert. We don't really want the tip of the endoscope making contact with the inner 2/3 of the ear canal, the bony part. So the design prevents it. So again, it's just because it's so narrow, I'm just trying to bring this through. Slowly but surely we're getting there. So I'm just using this method of like flicking upwards and then coming the opposite direction, so dragging it forwards. And it's just that top part of the ear canal, because it's a bit narrow there, it's getting trapped, but I think I'm through now. And again, it gives you a good idea of how narrow this patient's ear is. The wax is just trapped in between the front and back part of the ear canal walls. Back to the top again, just rolling it forwards. I could have potentially used a correct Jobson horn, but I was worried because it was such a soft consistency that would I spread it instead of kind of extract it. So I just continued with the suction probe here. Of course, an ear hook, it just sliced through it like a hot knife through butter, and forceps, again, it's just not suitable for this type, but managed to get out in a sizable chunk. So again, just going to remove some wax from the bottom, then we'll look at the eardrum. And when I visualize the eardrum, what I'm going to do is rotate the speculum so the slit is more to the towards kind of 10 o'clock. You can see I've just rotated it, and that's because the main hairs are from the back, so it just prevents the view being completely blocked by the hairs. I'm just going to get it in focus, and you'll just see how clearly you can see these blood capillaries on the eardrum, and you can actually see the incus just to the right of the handle of malleus there, which I was just shining there. So there's a slight retraction of the eardrum, and it's wrapped around the incus there. Well, I hope you enjoyed that video, guys. If you are interested in the WAXscope, please do feel free to email info@clearwax.co.uk. Thank you. Bye.